So today's discussion on staffing strategies, we're fortunate to have with us Dr. Romil Chadha from the University of Kentucky. And he is the interim division chief of the Division of Hospital Medicine and the medical director of Physician Information Technology Services and Telemetry at UK Healthcare. And Dr. Joshua Case, who's the medical director for hospital medicine at Northwell Health in New York. So with that, I'm going to turn it over to them. If you do have questions throughout the webinar, please enter those into the question box, and we'll have a moderated question and answer discussion after their brief talk. So Romil, Josh, take it away.
I would say I'll request Joshua to start early because he's in middle of it, and his experience is logarithmically higher than us right now. So I'll listen first.
All right, thanks, Romil. I appreciate that. So, yeah, I'd like to kind of present in brief our our strategy to this point. So Northwell Health, just to give a very brief summary, so we're the largest provider of healthcare in the New York metro area. My teams are the hospitalists at 15 adult medical surgical hospitals across the area throughout the boroughs of New York City, as well as Westchester and the counties on Long Island. As Dr. Chadha just mentioned, so we are in the midst of a logarithmic increase in the number of patients that are COVID positive that we are seeing in our health system, with our main tertiary site bearing the largest brunt of that. But we're also seeing a significant increase at all of our community sites as well. So our overall staffing strategy at this point is what I would call all hands on deck. An important part to think about is, so from our data, and this does seem to be consistent across the data from places that have seen this surge already, so 25 to 35% of your patients admitted with confirmed COVID-19 will require ICU level care. So an important part of your staffing strategies is collaborating either with your intensivist team, or if you are your intensivist team, planning to see that level of illness. So there's no way around that. So looking at that, so the first strategies are really communicating with our community physicians, whether that is someone that's employed with your health system that admits voluntarily to your facility or normally just takes care of folks out in the community, working through your administration, working through whatever avenues you have to identify who the people are that can come into the hospital and help. And making sure that any needed computer training is set up, and they've done that ahead of time, working through any credentialing issues, contract issues, to make sure we're able to get people in quickly and efficiently with a minimal amount of red tape. We can't have 4 to 6 week credentialing times right now. My needs are today, tomorrow, next week. Additionally, working not just with general internists and family medicine physicians, I'm also working with subspecialists, those that are able to care for medically acute patients, them becoming essentially a part of the hospitalist service, or perhaps those that let's say 20 years ago, they would have admitted their own patients. So let's say cardiology, which now admits their congestive heart failure, their atrial fibrillation, their non-STEMIs to the hospitalist service, partnering with them to take back over those patients, especially for those practices that don't necessarily feel comfortable with management of an acutely ill medical patient. And it's important to kind of get their feedback, especially in the beginning. Make sure you're putting people in a place for success. As people come into the hospital that are perhaps less familiar, we're beginning to partner them either with, let's say you have early residents in your facility, or you have a lot of NPs or PAs that perhaps, may be on surgery or something else, but know your EMR, know your systems, partnering them with someone who knows the medical knowledge, let's say an outpatient doc or someone like that who wants to help in the hospital, but doesn't have the knowledge of the systems of the hospital, of the EMR. We're also getting to the point now, so what we're calling is essentially a bit of a backfill. So letting those who have less acute care experience taking care of the less acutely ill patients, letting people with cardiology or oncology or those sorts of theologists helping to take care of their primary diagnoses that as hospitalists we had started to take over the last few years to help them increase their office practices, increase the number of elective procedures they're doing, which they're not doing right now because everything's canceled. So they've got that bandwidth. And even now looking at our hospitalists and getting them retrained, re-educated in critical care management, because again, as 25 to 35% of these patients wind up in our ICUs, depending on your community, you may not have that kind of resource to help manage that many critically ill patients. And looking at those strategies, that can be bringing in pulmonologists to help manage the manage the event with someone on ARDS if they have experience in that, and letting our hospitalists or other folks that are comfortable managing the other aspects of their care, or partnering with other specialties who have some comfort in the ICU, whether anesthesia and then hospitalists helping with that, or even having hospitalists manage these events. It's really an all hands on deck experience that we're going through right now. And again, I don't think there's any one size fits all for any community, any hospital. It's really looking at the resources that you have, thinking outside the box, thinking creatively. I think we know what skills we need to take care of an acutely ill ICU patient, and what skills do we need to take care of an acutely ill medical patient. And if it takes 2 or 3 healthcare providers to put together those pieces to take care of someone, that's kind of what we're doing at this point, because there's just not enough regular intensivists, there's not enough regular hospitalists. We need other people's help to be able to make it through this, or we won't be able to. And I've been absolutely floored with the responses, with the volunteerism, with the help that my teams have gotten. Basically, we've got folks lining up, just asking, how can I help? What can I do? And, take them up on that offer. So that's really where we're at right now within Northwell Health. So I'll pass it over to Dr. Chadha at this point, and you can kind of tell us what's going on with you guys.
Romil, please, Joshua. We use first name in our practice. Thanks. So we are a university center academic practice. I'll describe a little about state first. Kentucky, Midwest or South. I don't know exact location. It could be the northernmost southern state, or it could be Midwest, close to that. But we are like 4.5 million population, just 1/4 of the state of New York, where there are 26,000 cases, and we have only 160 cases right now. So we are not in that logarithmic period, and we will see the impact in coming 3 to 4 weeks, which will be full blown probably. And describing about our practice, we are a referral center. The whole enterprise gets 40,000 patients every year admitted and discharged. Out of those 40,000, 20,000 are actually referred patients. So half of our population is from another hospital or another ED, which makes us the 3rd highest in the country to get referral patients. Our patient baseline is also very different. If we look at the expected mortality, not observed, just expected of patient coming in, that's the highest in the country. We would not believe that one place sitting in middle of nowhere, Lexington, Kentucky, will have this kind of acuity. But when we get other experienced hospitalists from other places, they realize that how sick our population is, and the numbers point towards that in the CMI or Alex Hauser or Charleston Comorbidity Index. We are 73 physicians, 16 APPs. We have around 100,000 encounters every year, 10,000 discharges, 8,000 admissions, some 2,000 transfers from other services. We are kind of very stickler to the data, and we closely watch the variance in our teams. We have created all our 24 teams in a way that only 3 teams, the consults team, the admitting team at one side and admitting team at other side, which have pager responsibilities as well as continuity patients, have high variation. They have low expected numbers, but high variation. They can go from 2 to 30 patients, while all the other are very narrow bandwidth. They will go between 11 to 12 patients. And the reason we have done this is that because our volumes fluctuate, we want to absorb at least 20 to 30% patients without increasing our stress level or without bringing in our backup folks. We have 2 backup folks every day and night. So we have built those things in that. So currently, again, the whole state of Kentucky has only 160 patients right now, and Louisville and Lexington become the 2 large hubs for patient, and all the others are largely rural and community-based. Our plan is to absorb up to 20–30% increase in volume or decrease in staffing by using our backup 2 attendings and 1 APP every day till we can. The next problem which we'll face which when we go to around 30%, 40%, 80% increase in the volumes and numbers would be, as Joshua mentioned, to collaborate with our subspecialists, to collaborate with our surgeon. We also have graduate medical education trainees, which is residents and fellows. So some pilots I heard in New York were going on that to graduate the 4th year med student to start acting as an intern early on. We are not in that stage, but probably more hands on deck and more autonomy to the learners towards the end of graduation. The difference between the 3rd year resident in last month and the 1st year attending is just a day. So working with those population where the learners have high education, the MICU Pulm Critical Care Fellows, by the end of their 3-year Pulm Critical Care Fellowship or Cardiology Fellowship, they are extremely well trained and in taking care of very sick patients. These are some of the mechanisms for which we have helped with staffing. There is another area, again, we are just projecting when we will hit by the model which is put out by University of Pennsylvania. It's an excellent model in UPenn, which is free, and people can go and put in their hospital numbers into that, and it will project where you are and where you can get hit, and if what percentage of social distancing is going to help or decrease the volume. When we projected for us, if the social distancing works for Kentucky and Lexington, we might be seeing only 25% of the full-blown effect. So that's an important aspect. The foremost important thing for us is to take care of our workforce, take care of our colleagues right now. So we are trying to see to create teams which are COVID teams and non-COVID teams. There will be certain population we'll try to protect, like our colleagues who are pregnant, our colleagues who are immunocompromised. We are working with our Office for Institutional Equity and Equality to create models for them where they can work and not see patients because these are immunocompromised. Arranging the PPE for those people who saw Joshua's excellent webinar yesterday, it's the important part to give the material to safely take care of the patient, because if our workforce is affected, we have the same impact as increase in census, as increase in acuity of the patient. Childcare is another thing. So we projected for our whole university, we need 1,500 to 2,000 kids taken care of every day. So YMCAs have come up and we have partnered with them who are taking care of only healthcare professional kids less than age 5, non-school age going as well as school age going. We are working with some volunteer effect, which is med students, and they have created some Google Sheets where they are publicizing their information and their comfort with different age group of kids. That's a volunteer effect from med students. So we highly appreciate that. We are sharing information. The workforce of the nursing kids, for the nursing staff, for physician, for APPs, for pharmacists, for social workers, all these are sharing the resources they have. Something which we have thought about is, because we are a large group in just 2 sites, can we develop telemedicine exploration? Can we try to do something what Johns Hopkins was doing, which we heard in the JHM chat last Monday, that people are doing the pre-exam history as well as post-exam discussion on phones and limiting the exposure of physical exam to less than a minute, 2 minute, 3 minute, 4 minute kind of thing. Telemedicine is another thing. We have a lot of cross-cover calls at night. Can we divert our cross-cover calls at night to an off-site person who's either in quarantine or ill, but they can take calls, or immunocompromised or pregnant person who can, so that the person who was doing the cross-cover can admit more and more patients or take care of on-site things. So triaging these things into low acuity, high acuity, and critical care kind of thing. These are the models which we are talking about and experimenting currently. Some things again which we heard on the JHM chat completely, like we were a practice where like a white coat and a tie was an expected thing to get to scrubs, to have hospital clothes so we can protect hospital clothes, hospital shoes, to have some facilities provided, like could there be a place where people can take shower before going home? Could there be a place where they can bag up their hospital clothes and take home and put in laundry, or some scrub services where they can give their scrubs and get. So all these are things which we are planning for or working with.
Yeah, I echo that absolutely. That's a lot of stuff that we have played around with and have made available. There's childcare, scrubs, all those things, and I applaud you guys for being very proactive on that. And again, I think that it speaks to, you know, what are the needs, what are the resources that everyone has in their community, and work with that to do the best we can take care of these patients. I genuinely hope, Romil, that your community is spared what we're starting to experience here in New York. But I think the reason why we're both here is to help kind of spread the gospel and ideas and understanding, so that, you know, we can all be as prepared as we can be in our communities. And if, you know, we wind up over preparing for this, cheers to that.
And as Joshua said, that all hands on deck. When you get a text message from a vascular surgeon who's a specialized endovascular person, says, Romil, tell me, how can I help? How can I join in the workforce? I can put in lines very easily. I have managed vents. It has been 10 years, but I have managed vents. So these are the kind of people we need in any support we can get. There is no idea which is a bad idea. Thinking divergently, do not converge that this is a bad idea. Every idea is a good idea, and we can use every person who is ready to help.
Yep, and that's exact. The only answer is yes, and I will find something for you, even if it's just, you know, helping to answer phones, from absolutely anything and everything. We want and need that help in our groups, and, you know, take advantage of that help you're being offered. Don't turn it down.
Can both of you talk a little bit about if you have any plans in place, or how you might manage when staff members are exposed or even sick with COVID-19? How are you managing potential staff shortages, particularly when certain staff need to be quarantined for 7 days, 14 days before returning to work?
I think we've got a couple of our docs that are out right now with confirmed COVID. And that's, I think, part of the importance of having the redundant, having these conversations early, having extra people available, is that we're not able to fight. I used to always say, at least for myself, and I kind of held my teams to this, either you came to work in the hospital or you were in the hospital. And I think that was what our attitude used to be, and it can't be that now. We have to have respect for people having, which in the end we probably should have been doing before, but if you're sick, we have to take this seriously. And really, for my teams, it's COVID until proven otherwise, if you come down with a respiratory illness. So we have had a lot of folks that have needed to call out, and that redundancy is there. We have, having your employee health service, building up that robustness and building up the systems right now to have, what we have is, if someone has symptoms, they call EHS. We're very lucky in that we are able to run our own COVID tests. And so at this point, we're getting people in that day to get often that day to get a COVID test, so that we can determine very quickly whether they're able to come to work or whether they need to stay out because they're confirmed. For people that are coming back, so the CDC has put out some pretty good guidelines. And so it's, at this point, for healthcare workers, from my understanding, and correct me if I'm wrong, so it's 1 week from really from the time the test was taken. At that point, presuming that that person has been fever-free for 72 hours and symptomatology has meaningfully improved, with really the exception of cough, which can linger for a while, these people are able to return to work. We have a mask mandate in our institutions where everyone is wearing a procedure or surgical mask at all times, and that includes these folks. The interesting thing is that from what we understand is that these folks, once they recover, are actually probably immune, which, they still need to wear PPE, but they're able to return to the workforce successfully. We've had some folks that just aren't feeling well enough 1 week out, and that's okay. We're working with people as best we can, and that redundancy that we've built and the staffing strength has allowed us to do that while keeping safe patient to physician ratios at this point.
So as we are early on the curve right now, in UK, University of Kentucky Healthcare, our employee health and HR have already developed the policy around that. The facility for in-house testing, as Joshua said, that's extremely helpful because it decreases the lag time of uncertainty. Then the drive-through testings are being set up. That's on the outpatient location sites. Again, because we are early in the curve, only 160 patients in whole Kentucky, but we have the plans. So if you are in middle of it, do something. And if you're not in middle of it, it's coming, plan for it. Plan for having these things happen.
Yeah, I think working with your employee health and your hospital administration, working with whether it's state health department or whatever, to get the best mechanism possible to get this testing data back for the staff of the hospital as quickly as possible, so you can decide whether people need to be out or not. That's of critical importance. Until you get that test result back, they're out.
Great. Can you talk a little bit more about the covering COVID services? So, for example, on the swing shift or nighttime coverage, are the admitting physicians for the night or swing shift handling those patients, or are you only using COVID unit physicians to manage the COVID patients?
At this point, to be perfectly honest, nearly every single patient we're admitting is for COVID. That's the point we're at in our health system. And so, the COVID, we started out with, our night docs needed to see the patients. And so they were evaluating these patients. I think, it's critically important that you examine these, the ER STOM, that's fine. These patients can turn on a dime. That's one thing that we've really seen here is that they're stably sick, and then they cry. And so it's important to go and see those patients, making those visits brief. Absolutely. We're staying, we can do the history over the phone, give the plan over the phone, those sorts of things, stay 6 feet away or more. But you got to go in there and see these patients because you got to know what they look like because they can crash really quick. So at the beginning, I let it up to our teams as to, for the day-to-day rounding at the very beginning, how they wanted to handle the COVID patients. Because a lot of what you're going to deal with is the anxiety of your doctors, which is very real and needs to be recognized of, these patients are sick. I'm worried I'm going to get my family sick. I'm worried I'm going to get sick. That anxiety is real. It needs to be recognized. At the beginning, let your team decide amongst themselves, as long as it's reasonable, how they want to handle it. And I don't think there's a right or wrong answer. If you go to my PPE talk yesterday, everyone's going to have an N95 for literally until it stops working. So they're going to need that anyways. So, I don't think you're going to save much in the way of PPE by having one doc see them versus multiple, docs on the team. It will also help your teammates kind of get used to donning and doffing and those sorts of things. But if you get to the point we're at right now, there is no non-COVID unit. It's everybody, it's everywhere.
Yep. And I'm on the same lines as Joshua. Our initial plans right now, because we are early in the curve, is rather than we started with having COVID teams, COVID locations, but now we are going to COVID sparing teams. So protect certain people because even for rule outs, there will be 10 times the number of rule outs for every COVID positive patient in the initial phase. So you still have to configure the floor plan or the team for, yes, this is a test pending patient, this is a rule out patient, and then later 1/10 might become positive at our community level at this point, or less than 1/10 at this point. But what we are focusing now going from COVID team, COVID floor to COVID sparing floor, COVID sparing team, and then we will come to the point what Josh was saying, that almost every patient will be. Because we have learners and our bylaws are written in a way that every APP patient could be staffed with an attending, we are trying to avoid those things. So if an APP is staffing the patient, if they don't need clinical help, they do not need to, there's no need for attending to see the patient. For the patients which we admit after midnight, we will ask just one attending to see the patient, and the resident who admitted overnight can check out to that attending. So we are doing some strategies, but still we do not have a different night COVID team if there is an urgency or emergency overnight to cross cover. So the nights are like all in.
Mm-hmm. Yeah, and just at one point, our positivity rate at this point is over 50%. So that will change.
That will change, yes.
Yes, yeah. It's gone through the roof. Yeah.
We had 2 questions about financing. The first is, do you have a compensation policy for employees who are quarantined, and how that's being managed? And then the second is if either of you have thoughts on how a small practice might be able to finance extra staffing needs, or approach financing some of these extra staffing needs that they might have.
Yeah, so for the financing perspective, this is a problem, and we're all our health system we're looking at a hit in the order of magnitude of billions of dollars for Northwell Health. I think every practice, every health system is going to take an enormous financial hit on this. My understanding, and I haven't had a look at the legislation yet, but the legislation today that was passed in the Senate does begin to address this. And so we're in the end going to wind up getting paid one way or another. The finances are going to be a problem though for a little while. As to what we're paying people to come in and see patients, we're not paying some astronomical rate. I think a lot of, we're paying, I get what I call our regular emergency rate. But for most doctors, this is not about the money. This is, I think, why people went to medical school, was to help people, and this is the siren call for helping people. So we're avoiding, we think we're at this point providing very, normal and fair compensation, for as a daily per diem rate, basically above and beyond what people would normally be working. And it's not been about money for people, which has been really, I think that just speaks to the goodness that the vast majority of physicians have in their heart. At this point, this is about helping people, and we'll deal with the finances on the back end.
So I am with Joshua too on this, that probably we'll figure out, we'll pay just our regular moonlighting rates, what we have for each shifts, and then the larger impact would be figured out later. This is about helping patients, and this is the reason I am in medicine, and this is the reason all my colleagues are in medicine. This is our calling at this point. Regarding the smaller community hospital, what I would say is the bond between a community hospitalist and the specialist is way more stronger than a larger center, a group which has like 10, 15 hospitals, an academic center. So those are the people to look for, because they can very well manage these patients, to work with the hospital to get those patients, people inpatient. Because in the initial phase, almost all hospitals or community hospitals will see that their regular garden variety, low acuity, mild cases are going to disappear. They are not going to come. They will not come for minor problem to the hospital, to the emergency room, to the clinic. A lot of things in that area could be quickly changed to telemedicine as per the expanded alliances in the current CMS and some private insurers which are going through. So they will be available. They will be willing to help, and asking for help when needed is not a bad thing.
Yeah, I think I've before I started with Northwell, my practices were either rural or smaller communities, or really at different places across the country. And from my time there, I mean, the folks that you work with as a hospitalist, they're members of the community. They are invested in that community in more ways than I think a lot of us can imagine, and they're going to be there to help the folks in their community. They'll be there to help.